We're gonna hand over to our next speaker. Apparently this gentleman is very famous, and everyone in this room is likely to know who he is. I from Sydney did not quite realise that he looked famous. He looked really familiar. And I only realised today how actually incredibly famous he is, and what an amazing opportunity to hear from Professor Brett Sutton. So please come along, and I'm not going to go through your resume, but welcome.
Thanks, Sinead, and lovely to be here and to see everyone. Yeah, there are still people who come up to me and think they know me maybe from kids' soccer or swimming, so I do have that face maybe. I'd also like to acknowledge, I think we're at the convergence of the Bunurong and Wurundjeri countries here. This is a very important part of the CBD for Aboriginal Victorians, and there's a nexus of those brothers and sisters of Aboriginal people in Victoria right here. So, AI. I'm going to talk about a little bit of a snapshot in AI and healthcare and what the future holds from a CSIRO perspective. And it's been said before, but AI can't do stuff on its own. There's no question that there's this foundational level that is really significant in enabling AI to be at its most effective, if you like. And interoperability has been spoken of, the ability to call on data sets to have the intersection of intelligence in order for it to be interrogated with the tools that AI provide for us. So ensuring that that data can be safely exchanged is really critical. CSIRO is doing some work in that space with FHIR, HL7 messaging, the Sparked accelerator program that the Commonwealth has supported, and SNOMED CT, so clinical terminology, getting the terminology right so that you can share, you've got the same language that enables that interoperability. Cloud computing, obviously important from a storage exchange democratisation point of view, really important, again, as an enabler. Apps and personalisation, so the availability of patient data, again, that's been spoken of today. And data analytics as a service, so the idea that algorithms can be brought to the data rather than having individualised data being stored everywhere. Doesn't mean that we shouldn't have a federated system of data. We should have a federated system and then be able to use the interconnectedness of those data sets for maximal effect. In AI, there are really four domains in healthcare in general terms: knowledge, representation and reasoning, imaging and vision, predictive analytics and data-driven intelligence, and human language understanding. And I don't know if this was spoken of this morning, but the symbolic AI and statistical AI, obviously we're talking about generative AI here rather than the AI that emerged in the 1960s, the kind of narrow AI or traditional AI. But symbolic AI, you can think of it as high curation with a bit of a top-down approach to the rules that helps to establish the strength of correlation between events and outcomes, whereas statistical AI, less curation required, but big data analytics enabled nonetheless. And the beauty about health sector more broadly is that both of these are at play and should be at play. And, you know, there's sometimes descriptions of a hierarchy of AI in terms of artificial general intelligence, Terminator, understanding the world, to AI, to machine learning, to deep learning. And it's not necessarily a hierarchy in the sense that one is better than the other. There'll be curated forms of data analytics that are appropriate in different contexts. And sometimes machine learning is the more appropriate tool in that space versus generative AI. We have crossed the Rubicon. I think we have to recognise that we've crossed the Rubicon. So AI is absolutely an inevitable part of the digital transformation of health, and it's working in all of these spaces. You know, I think one of the things about it being inevitable is that we've got lots of catching up to do in lots of spaces, and we talked about some of the ecosystem challenges this morning, and we really need to push on in that regard. At the same time, there are some dangers here, and there are some things that we need to not stop or pause or slow down, but to get ahead of. And I think the reg policy, legislative and regulatory frameworks is one of those. We shouldn't stop everything in order for regulation to be thought about, drafted, consulted on, but we need to crack on with that consultation process now so that the drafting of the appropriate regulatory framework is in place for the developments that will inevitably come in pretty rapid succession with AI. Lots of challenges and opportunities in this space. You know, these are just some portfolio areas that you can think about, or some context that you can think about. You know, in the chatbot space with ChatGPT, the medical records interrogation and collation and summarising. There are GPs who already use chatbots in order to write case notes to sound more empathetic than they might otherwise. So, you know, there's, and Tam showed us, there are lots of spaces in which chatbots or LLMs can play in. In the imaging world, I think that's a really exciting space, and I know Johan spoke with the same kind of enthusiasm. It's an area where efficiencies, it's so ripe for efficiencies. It's such an intensive human process up to this point in time, and we're at the verge of being able to have equivalent interrogation of those that will be at or above a human level of analysis. So in the automation, prediction and detection space. Workforce, both challenge and opportunity, clearly. There are not enough clinicians. We need to go to models where there can be clinical interactions supported by AI that do not take all of the time and space of clinicians. And of course, clinicians, and again we've heard this, can be overwhelmed by the enormous amounts of data that they have to trawl through, or the barrage of information that they get. What did they do with pilots who had 100 bits of instrument that they needed to get across in order to fly a plane safely? They automated it. And now really there's a bit of AI that is flying our planes every single day. And the pilots are still there as the stewards of that and still have to make those final decisions. But they're getting prompts that are collating all of those data inputs in real time. Aged care, again, I think we're held back in aged care more by the conceptual framework and the orthodoxy of care in aged care, as opposed to the way that technology could apply in that space. There's so much opportunity for vigilance and early detection of emergent illness, so that default of call the ambulance and get them to hospital because we don't know what's going on shouldn't be the case. It should not be the case that someone with a UTI who could be identified early, treated early, because there is an exquisitely sensitive mechanism of detection, and it might be a combination of remote sensors and AI interrogation of multiple inputs of bioinformatics in order to say, do something now, as opposed to 48 hours or 72 hours from now. Consent and dynamic consent, again, I'd like to re-emphasise that. And disability. There are opportunities here for increased inclusion in the residential disability space, in the disability support services, and equality needs to be at the heart of that. But the requirement is that a client or patient or person-centred approach needs to be at the absolute heart of that, because if we're designing without putting people in the centre of it, we will not be serving their best interests and their priorities and needs. The big questions for me, or some of the big questions for me in clinical decision making, and maybe they'll come to the panel, I'll speak just briefly to them, or a couple of them, how do we go beyond safety, quality and efficacy and make sure that we don't regard a safe, quality and efficacious tool as sufficient. It's necessary, but it's not sufficient. We need to address those biases that might creep in, conscious and unconscious, but also those biases that will be inherent because we're making a value-based choice between, for example, sensitivity and specificity. When we choose, we will bias in one direction or another. Are we throwing the net very wide and therefore capturing everything, but bringing in some false positives, or are we throwing a very narrow net and missing some individuals? They are value-based choices, and it does in some part go down to what will be the most accurate, but there are other questions that really relate to how much are we happy about over-investigating, over-diagnosing, or how much do we really just want to capture those true cases? What is equity in AI? And I'm glad that Tam brought it up as equity of outcomes, because equity of access will not do enough. And unless you have some of those biases explicitly called out, invigilated and addressed, then you might have a very safe and quality tool that fails to recognise those individuals with rare diseases, for example, or some of those underrepresented cohorts. And so they may have access to the tool, but is the tool managing and interrogating their bioinformatics in a way that serves and supports them equally and equitably? How does AI take account of the messiness of the human condition? I think this is a curious one, and it struck me when I read a paper that talked about the fact that 1 in every 3 GP consultations has an issue that is not raised by the patient. So you'll come in and you'll say, oh yeah, my asthma's worse. That's the story you tell, but what's the real story? Oh, actually, sex with my husband or wife or partner is pretty poor, and I think they might be having an affair, and I'm really stressed, and I'm smoking more, and my asthma's worse because of that. But not saying that is an issue. And so what's the space that AI can help in this regard? And we've talked about the fact that maybe trust is engendered by having a chatbot as your primary point of contact. But what are the implications of that? And maybe it'll be that people feel more comfortable, but then what are the expectations for the real world primary caregivers and clinicians, and what the expectations are of them in a world where they're overworked and underpaid and get frustrated and may not be able to generate the empathy that a chatbot can do 24/7, 7 days a week. There will be denial and deceit and discomfort in those clinical interactions, and we need to be mindful of that. If someone has a positive pregnancy test and bursts into tears, I imagine a GP is in a better place than an AI to know whether those are tears of joy or tears of despair. And so that fuller context is always going to be important. I think we need to understand that that human component can probably never be replaced, even if there's really powerful accuracy in terms of diagnostic acumen from AI. And so let's always bear that in mind. And will AI overcome that uncanny valley effect? So in robotics, it's when you know, not quite right in terms of how a robot looks. I think there can be a component of that in chatbots as well, when in a mental health chatbot, all of a sudden you get a response back and it's not quite right. I remember the New York journalist who spoke to an early version of ChatGPT that suddenly said, I do love you, and wouldn't let go of it. Spoke for 45 minutes about how they were absolutely in love, and the journalist was trying to come back and say, no, I'm happily married and I've just had a really lovely Valentine's Day, and the chatbot retorted, no, you haven't. You had a really, really dull day. And so we have to think about what some of those hallucinations might mean in the world of AI as well. There was another case in the US, a legal case, where they were using AI as a paralegal replacement, because paralegal work is a real drudgery, maybe especially in the US where there's so much case law. But they used AI and were told case law that didn't exist. And so I can't remember what they referenced, but it was in a high court or state Supreme Court case, and they talked about, you know, McConaughey versus the state, 1976, and it didn't exist. And so we need to think about what that might mean for a really critical piece of recommendation or advice that comes out of a clinical engagement. I hope we talk about the potential dangers of a commercial race to the bottom. We are suffering from our own bias here. We're projecting the use of AI and the future state of AI in a way that we would like to see it used and in a way that we would be motivated to use it. But we also have to think about those use cases where the most nefarious minds would want to use it. I don't think any of us thought that the biggest commercial drivers of AI in the world might be deep fakes and porn and overturning elections, but that looks like a genuine growth area, and so we have to be able to get out of our own space here and say, what are some of the genuine dangers here that might apply in a health space? And I think there might be patients who are absolutely willing and motivated to litigate clinicians because they've been told to do something, and AI that was known to be more accurate than a human consultation was ignored. And we might say, oh yes, but that was a clinician working with the best information that they had and using their best judgment. But was this using AI framed as a medical device? Or will we be in a space at some point where that AI is seen as a peer, a reasonable peer who might be outperforming a human peer? I don't know how AHPRA might feel about that, but at the moment, I think it's sufficiently concerning enough about how clinical decisions are made with AI available, with best practice potentially being accessible to clinicians and not used. And we heard also earlier today who's responsible, accountable, legally and morally liable in those circumstances where advice is followed or not followed. And I don't think it's straightforward. Again, we might frame ourselves as saying, look, it's a clinician's making a choice, and their peer review is from other humans, but we have to imagine a world in which the expectations might be different in that space. Thank you so much. Oh, final plug. The CSIRO AI Trends for Healthcare report comes out tomorrow. Stuff on AI and machine learning and some fantastic case studies, including, interrogation of Alzheimer's disease, MRIs and tau and beta amyloid proteins that have brought diagnosis 10 years, 15 years before clinical emergence, that allows for medications to be used, that allows for early interventions that can make a huge difference from a tertiary, secondary prevention point of view. Thanks so much.